All right. Well, folks, thanks to everybody. I guess welcome. Thanks for joining us today for the webinar. My name is Aaron Lieberman. I'm the Executive Director of the Idaho Outfitters and Guides Association. Today, I'm going to be pretty brief. Today, we're presenting Rural Idaho and the Outdoor Recreation Industry Testing Symposium. We were trying to come up with a neat initialism or acronym there, but couldn't quite get it. It's going to be led by Chalice-based outfitter and leader of the IOGA 019 Taskforce, Steve Zettel. You'll see it several places there. Little housekeeping before we get started. Just so you're aware, this webinar is being recorded, and that recording will be made available, as well as hopefully some notes outlining any learnings from the webinar on the 019 website, and I'll put that up in the chat here in just a moment. If you do have any questions during the presentation, please type them into the Q&A or question box in your Zoom control panel, not into the chat. Feel free to use the chat to message to me or each other directly, but Q&A for any of those questions, and we'll hopefully have time to hit some of those. We'll also have time for questions at points throughout the webinar, and again, hopefully at the end. Without further ado, I'll pass it over to Steve.
All right, so as Aaron said, I'm an outfitter here in Chalice, and I'm going to apologize in advance because we're all about the product here, not the production. So, you know, we're outfitters, we're not Zoom masters. So I'm going to begin to hit some of the base stuff before we break into the whole group, just to sort of establish the rules and the direction and what maybe we're hoping to accomplish here. So bear with me for the next 10-15 minutes, and might answer some questions of what we're trying to accomplish. So first off, I'm joined by my wife, Jess, who's off to my left. And if you see a second picture of Steve Zettel, that's actually Jessica Zettel. So, and then once again, Aaron Lieberman, he is actually the brains behind the operation. I'm just the good looks. So the 019 committee, we're a subcommittee of the Outfitters and Guides Association, and we formed to address everything COVID-19 and outfitting in Idaho. We are everything from goat packers to 5-star wilderness lodges and everything you can imagine in between. Big game hunts and jet boats and whitewater boating and rock climbing, you name it. If it's outdoors, we're probably doing it here in Idaho. Let's see where we at. Our first concern for 019, without a doubt, was not better face masks, was not finding, you know, better disinfectant. It was addressing the small communities of Idaho and their concerns with not only COVID-19, but with tourism, and more specifically with outfitting coming on, and the influx of folks that we're going to bring to those communities. So the first calls we made were to the mayors of small towns. To that point, it's one of the main reasons we're here today. We're still addressing those concerns of the small town, and you'll see that play out as we move along here. So, okay, the Idaho Outfitters and Guides Association is essentially a group of outfitters, you know, with a common cause. There's about 400 outfitters in Idaho. There's thousands of guides, and statistics tell me we're going to take a couple 100,000 guests here in Idaho, a lot of those coming from out of state. And, you know, some of those are just, you know, for a half-day trip or a full-day trip, or maybe they came in on their own and they do a trip with an outfitter and then they go off and play by themselves. And some of them are destination vacation folks coming here for a week, river trip, pack trip, big game hunt. That's a lot of people entering our environment. I heard the other day that Stanley, Idaho, it's got a standing population of, I'll get it wrong, let's say it's somewhere near 80. It's supposed to have 1 million thereabout visitors this season. So you got a little clinic there that's trying to, you know, year round manage 80 people, and now potentially the influx of 1 million coming through there, and what that suddenly means to a small clinic. Okay, so the parameters for today's discussion, once again, remember the product is more important than the production, so bear with us. We are recording, once again, in case somebody didn't hear that, we are taking notes. When we talk testing today, it's important that we all understand that that testing is a big word, and anyway, we are talking the testing associated with commerce. Okay, I think we all understand the point now that there's testing for the medical end of things. You know, if somebody's sick, the frontline folks, you know, we get it. There's also now, with the push of opening up the country again, the need or the perceived need of testing in commerce. And so let's try to hold our conversations as much as possible to testing as it relates to commerce. I don't know if that's a good term, but that's the way I broke it out: medical versus commerce. So today's conversation is on commerce. We also understand that there is no perfection in any of this. Okay, so the notion that because something's only 80% accurate, it's not worth doing. You know, that's not true, as we all know, especially the professionals in this group, that, you know, if you get a broad-based enough study, you know, 80% accuracy is probably pretty doggone good. So for the group, we all get it. If you go in and you get a test and it says you're negative, that doesn't mean you go out and start dancing and hanging out. You know, you still play by the rules. You know, testing is not meant for the individual. We understand that it's meant on a community-wide or an industry-wide or whatever, a statewide basis, not just do I have it or don't I. So I think we get it. There is no perfect, no right or wrong. The only thing we can do right today is the potential of improving the system that we have in play, if possible. That's where we're heading. Okay, we also, as an industry, we have outfitters right now who are basically testing for individual reasons. And I'm not saying that's right or wrong. I think that's a fine thing. Everyone should make their own business decisions. And I think the same goes for folks in the other sectors of business where they see a benefit to testing all their employees at whatever kind of a, you know, schedule they see fit. We have a couple of folks, you know, on our panel that represent groups that those folks are testing with, and we think that's great. We also are going to discuss some potentials for masterminding more of an industry-wide or a community-wide testing, so that you know, instead of just onesie-twosie companies out there just doing it maybe so they look better or feel better, we can do it for a more practical reason based on maybe what the experts in this group, you know, say today. Okay, and I'm just going to read this verbatim. You know, I'd like to believe that if done right, commerce testing, especially when tourism is involved, remember those hundreds of thousands of guests coming, you know, may actually prevent the need for medical testing. So when we start talking about the you know, the ratio of how much resources available for commerce testing versus medical testing, that, you know, the potential of eliminating threats may actually save testing on the medical end if we do it right on the commerce end. That's a notion that other people are discussing as well, and we'll discuss that as a group, hopefully. So our mission today, we're going to learn about the options. We're going to learn about available resources. We're going to try to pinpoint the shortcomings in the system to date. We're going to attempt to predict the future of testing and ultimately tweak the system into one that not only improves consumer confidence, but truly adds to the safety of our rural communities of Idaho, our guests, our associated businesses, our employees, and ourselves. So that's pretty long-winded, but basically if we can come up with a plan that helps the small towns of Idaho and those that live there, why not? And if we can't, that's a good answer too. Sometimes no is an okay answer. It's an answer. I'm going to roll into two examples, actually 3 examples, personal examples. I'm just one person, so I'm a microcosm, but if these 3 affected me so much, just think how it does, on a national level. So number 1, scheduled to go to Keys for a month, couldn't go. They blockaded the road, closed Monroe County, couldn't go to the Florida Keys, had to change airline tickets, vacation time, okay? That's one way of handling it, right? Close the gates, shut her down. In a place like Idaho, Stanley, Riggins, Chalice, boy, that's easy, right? I got 3 roads coming into Chalice, blockaded, nobody comes in. We don't really see that as a viable option. We've sort of made that commitment. We're opening up, but there's a county that did it, and there might be more. All right. Second option, I'm scheduled to go to Alaska in a couple weeks. Going to go salmon fishing. Can't go until I get a negative COVID-19 test within 72 hours of my travel. They've basically virtually have closed the border and said, if you prove negative, you can come in, right? All right, there's another option, right? So to give you an idea what a big deal that is, just in my little world in the last 24 hours, and I didn't go out and recruit this comment, I communicated with 18 people that need a COVID-19 test in the next 30 days to go to Alaska, just in my little group. So imagine, the calls that locals here are going to get about, hey, I give you a couple $100, will you give me a negative test? I mean, we can see that coming, okay? So let's put Alaska over here just for a minute. Just bear with me, because I think it's going to come back. Probably not appropriate. We're all going, ooh, we're not going to close the borders of Idaho, but let's just leave it out there just for a minute. Okay, let's go down to, let's all get on our airplane, fly down to Moab, Utah. Okay, Moab is the reason I'm here right now, is because I fell off my bike this spring, injured my shoulder, had surgery, so I'm not out in the woods doing my thing. I'm sitting here talking with you folks because I'm recovering. But here's what Moab decided to do with their tourist industry. They decided that they were going to test for free all their frontline, and I want to make sure it's clear, frontline commerce folks, okay? Not their ambulance drivers, not their ER docs. That's a different deal, right? This is their frontline commerce folks. So guides for one, all their guides. If you've never been to Moab, if you do anything outside, they do it. They embrace it. You got runners and motorcycles and rock climbers and whitewater, and if you can come up with a toy that'll go out in the hills and run around, they'll let you do it, okay? So they've got bazillion guides, they got operators, they got all this stuff. They got thousands of people coming just willy-nilly in there, all right? They also included the rest of their frontline folks. I can't be real specific, but I'm assuming it's probably grocery store clerks and bus drivers and all these folks. And then what they said was, we're going to come up with a system that allows us to test them. And it was the hospital board that did it. The hospital board said, look, we put money in the bank. We've got money from the CARES Act. Let's go out and see if we can figure this out. So they hired a nurse who was running the local free clinic, and they put him in charge of it. And this guy came up with this system. And so what they did, they sistered up with the satellite branch of the Mayo Clinic that's in northern Arizona, and they decided they would test 200 of these frontliners every week. That's their goal, 200. Not the same 200, different 200. And their goal is to test everybody at least once a month. And they didn't say it specifically, but I looked at it like, okay, what they're saying is it's the old canary in the coal mine. If we've got thousands of guests coming, the people that are meeting those guests are probably somewhat a little more at risk than the little lady down the road that only comes to town to buy groceries and get her mail. So if we keep our finger on the pulse with this core group and rotate them through, then we'll have a feel of how tourism is actually affecting this small town in Utah. So there's the other option. And that all sounds really good. Now, remember I said we're going to go back to Alaska. And because this is sponsored by the Idaho Outfitters and Guides Association, this meeting here, I want to address something very specific. I mentioned earlier, all these different activities that we represent. Some of these activities are very technical and take extensive training to do. My Middle Fork operation takes highly trained guides. I got to invest a lot of time in them. And then ideally we take folks down the river a little safer than we would if I went up to the bar and hired a bunch of guys and we just went for the first time. So that's what we do. But here's the reality. If tomorrow every one of my Middle Fork guides couldn't make it, I could probably go get 6 other guides, and they might screw up my menu and they wouldn't really know the color of my boats and everything else. But the reality is they could get in the boat. It's got the same kind of oars. They could get down, they'd figure it out, and they could make the trip happen. But we have other activities in Idaho that are different, and they're different because the expertise changes immensely. Once we add livestock to that equation, suddenly I can't go get 6 people that don't know my 30, 50, 80 head of horses. They don't know which one's buck, which ones are rideable, which ones you can only pack. They don't know how to go up some strange canyon where the campsite is, where the water is, where the elk are, all that kind of stuff. And so the point would be that suddenly I'm less concerned about the health of my guides from a perspective of just monitoring them. I suddenly truly want to protect my guides. Because when I get into the fall, I'm going to be in the backcountry and I'm going to have this little village that's Idaho Wilderness Company. And no longer am I taking groups like I might take on the river, which might be 10, 20, 24, or whatever. I'm suddenly taking groups that are, 2, 4, okay? Those I can manage. It's a lot different. It's be tough for me to manage a group of 24 coming in from all over the place. What they're doing 2 or 3 days before the trip, what they do after, I can't do it. It's almost impossible. But I can manage 2 or 3 or 4. And so now my focus is I'm looking back at Alaska going, I want to protect my village. So now I want to lean on more of the Alaska notion of, I'm gonna say you 4 have to show me you're healthy before you come to my village. And so I'm just a microcosm of that. We probably got between 50 and 100 hunting outfitters in Idaho, if I had to guess, and they're all going to be thinking the same thing. And so that sort of testing, I believe, is going to come into play, not so much right now, maybe a little bit here in the summer with pack trips and whatnot, but as we roll into late August, those ratios go down to 1 guide to 2 hunters. Sometimes it's 2 guides to 1 hunter. So it's a lot easier to manage that one hunter than it is for me to manage my 2 guides. Probably the answer is going to be I'm going to do both. Okay. So with all that said, I really appreciate you bearing with me. I'm going to turn it over to Dr. Chris Ball, and I'm going to have him enlighten us at an outfitter's level of intellectual capacity of the basics of testing, what's really being used. I realize if there's dozens, what are the 3, 4, 5 that are really being used in Idaho? And then I'll kind of spoon feed you some notes as we go. But if you could start with that and make sure you're off mute there. You go by Dr.
And
Ball.
Steve, can I just ask?
Sorry,
can you just introduce everybody first, real quickly?
I'm sorry. That's why I skipped a step in my own deal. I am going to introduce the group right now. And let's see, where are you? So first off, I'm going to introduce Dr. Matthew Dawson, MD. He's the founder and CEO of Wild Health. They're located in Kentucky. And at some point in this conversation, not too long from now, I'm going to let him explain exactly what he does. But thanks for being with us, Dr. Dawson. We also have Jeannie Gentry. She's the CEO of the Steele Memorial Hospital in Salmon, Idaho. And we have Elke Shaw Tuluk. I'm sorry if I kill that one, but I'll get it close. She's the MHS Administrator, Division of Public Health, Idaho Department of Health and Welfare. Thanks for being with us. We also have Tina Upson, Executive Director of Crush the Curve, and she's a go-getter, and I really appreciate her being here. Dr. Chris Carter is actually works for the CDC, and she's the Jack Ryan of the CDC. She's a special agent here in Idaho, and I can't say the word, but she's an epidemiologist by trade, and a very, very bright young lady. Then we have Dr. Chris Ball. He was on the, in fact, he was the co-chair of the governor's task force on testing, he is also the bureau chief and laboratory director of the Idaho Bureau of Laboratories, specializing in pathology. And his cohort on that task force was Dr. Jim Souza, who was the chief medical officer for St. Luke's health system. And then we have Jeff Bitton, who is the Idaho Outfitters and Guides president, longstanding outfitter, and I believe maybe second or third generation outfitter living in the Stanley Basin.
And one of those 80 people in Stanley.
Yeah, one of those 80 people. So I believe I got everybody. Don't worry, when you get called upon, we're going to let you give yourself a little intro. But for right now, let's get to Dr. Chris Ball and a little introduction on testing.
Great, thanks everybody. Can you hear me?
We can.
Okay. Now that you mentioned I have to get it down to the outfitters level, I would say down to, I'd say, why, I'll just go straight shooting. You guys outfitters, some of the smartest people I know. So what I was asked to do is just provide kind of a general overview of testing options, both availability here in Idaho locally, and some considerations that you may want to think about in terms of test reliability, cost. I will be less able to speak to directly. It's a very unsettled matter at this point. So why don't I just start off with talking about types of tests. I know that was one of the things that was of most interest, is kind of looking at the testing options as we survey the landscape. So the one thing that I can say about the testing environment is it has been very dynamic. It changes regularly. Every week there are new test methods that get authorized for use by the Food and Drug Administration under a special provision in the Food, Drug, and Cosmetics Act that allows them to give an emergency use authorization. What that emergency use authorization means is that the methods that they are authorizing have not gone through the full FDA approval process. So a lot of the tests that are available right now, there are currently 96 different tests that have an emergency use authorization. They've gone through some level of validation, but all of these tests, there's still a great deal of uncertainty about performance characteristics. As they get utilized more and we test more with them, and we have the ability to compare test results with clinical findings, then the confidence that we have in these tests increases. So one of the things that I think is really important to kind of level set everybody is that none of these tests have gone through a traditional FDA approval process. The other thing that I will tell you as kind of broad caveats before we get into the types of testing that are involved is that all of these tests have been authorized for use in people that are symptomatic or have signs of COVID-like illness. The other thing that I will say is that we are, as a laboratory community, are still very uncertain as to how these tests will perform when you're dealing with people that do not have obvious signs of illness or are presumed to be negative. So there's a great deal that we still have to learn about the performance of these tests when you're using them on populations that the tests weren't designed for. The other thing that I'll mention is that all of the tests that have been authorized for use by the FDA are all by prescription only. So what that means is, in the state of Idaho, those tests have to be ordered by somebody who is an authorized provider. An authorized provider is anybody who's licensed to practice medicine in the state of Idaho and has test ordering in their scope of work or their scope of practice. So that's a fairly broad group of healthcare workers or healthcare professionals in the state of Idaho. So that's physicians, PAs, nurse practitioners, dentists, pharmacists. There's a wide variety of people that have test ordering within their scope of practice. So if we're really focusing on employer-centric testing, so employees trying to test people outside of the medical environment, the only way that that's going to be possible is to have the employer work with somebody who is authorized to order tests. So those are kind of my opening remarks to kind of set the stage for you. So regardless of what the intent of the use is, we need to be working with a healthcare professional to get that test ordered, and then also to direct any post-care that may be needed once the test result comes back. And there are a number of healthcare providers, even in rural settings, that could serve in that role. Another option to consider is that it would be good to work closely with your local public health districts. All of your local public health districts have offices in each of the counties that they serve, and they all have medical directors that help guide the clinical services that they provide. So they can be a great resource to you, not only in providing guidance on how best to ensure that the folks that you're working with are going to be safe and your staff are going to be safe, but they also can provide an avenue towards getting some testing options potentially on the board. So with those broad sort of caveats, I'll just talk a little bit about of those 96 tests that have been currently authorized from the Food and Drug Administration. The vast majority of them, so of those 96, I think there are only 4 test methods that are currently approved for use in the point of care setting. So that would be small clinics or pharmacies or those types of settings. The vast majority of these tests have to be performed in a high complexity or moderate complexity laboratory. So there are really kind of 2, if you will, buckets of testing. In one bucket of testing is what we would call the diagnostic tests. And these are primarily molecular tests. They use a method called polymerase chain reaction, or PCR, to detect pieces of the SARS coronavirus genome. And when we determine or when we detect that genomic material in a person's specimen, that would indicate they have been infected with the virus. That does not mean that they are currently infectious. One of the things that has been very interesting and hard for people to work with is that on average, once a person tests positive by a PCR method, by PCR, you can still typically detect remnants of that infectious agent, that SARS coronavirus, in a person for upwards of 3 weeks. And so if you match the PCR results with the actual clinical outcomes, so following them through the course of disease, in most healthy folks that get infected with SARS coronavirus, their symptoms will resolve and they will be perfectly healthy, but they'll still potentially be able to have a positive detection with a PCR test. The vast majority, I would say 95% of the tests that are currently available are going to detect or be diagnosing SARS coronavirus or COVID-19 disease using a PCR-based test. The availability of these tests is improving. Almost all of the major health systems in the state have the ability to perform some testing in-house. Also, there are a number of large reference laboratories that can process tests at a very high throughput. Capacity has increased substantially since this all started in February. And I expect that it will continue to advance through the course of the summer. One of the things that early on laboratories have been most challenged with is because of the unprecedented nature of testing and the testing requirements, everybody was pulling from the same supply chains, and availability of materials to perform this high complexity testing was really, really limited. And the vast majority of the materials were going to the areas that had the highest disease burden. So what we're seeing now is that the manufacturers have been able to increase their production capabilities. And we're also seeing the federal government step in and assist with the procurement and deployment of materials that is improving access for more rural states like Idaho. We have been able to work through HHS and our partners at Abbott Laboratories to deploy a rapid point of care test that does use a molecular method. It's called the Abbott ID Now system, to a variety of locations throughout Idaho. And many of the rural clinics that serve the Idaho outfitters and guides have this instrument, and we're supplying them with testing reagents to try to fit their demand. That being said, we have a limited amount of materials that are getting allocated to us on a weekly basis. So we're trying to do the best we can to get them where they need to be. So on another note, still in this diagnostic testing bucket, if you will, there is another type of test that holds a lot of promise for the type of testing that you're talking about here. So employer-based testing, or testing outside of a predominantly medical setting. And these are what they call a rapid antigen test. So it's still a diagnostic test. The purpose of the test is to determine whether somebody has an active infection. But rather than looking at little pieces of its genome, what the antigen test does is look for proteins that are on the surface of the virus. And in this case, these antigen tests can be widely deployed because they're relatively inexpensive to manufacture compared to the molecular diagnostics. And they're set themselves up really well for rapid screening or serial testing, which is when you're testing the same person or same group of people over and over again. Currently, there's only one test system. It's manufactured by a company called Quidel. It's the Quidel Sofia 2 rapid antigen test that has an emergency use authorization from the FDA. However, in conversations that I've had with the FDA and on national calls that I've been in, there are several other rapid antigen products that are currently in that pre-EUA validation process. And the hope is that they will become increasingly available as the summer moves on. These tests will most likely, once approved, be available in a point of care setting. So kind of expanding that applicability for use to places like retail pharmacies or doctor's offices. At this point, I don't see anything that is designed for at-home use. So I don't think that there's anything in the pipeline that I've heard about that would be a reliable and valuable test that somebody could just purchase at a pharmacy and take it home, like a pregnancy test, for example. So I think in the discussions that you're most concerned about, which is trying to prevent the spread or transmission of disease amongst your staff and amongst your patrons, I think that the most promising test coming forward that will provide both availability, timeliness, and lower cost are going to be the rapid antigen tests as they become available. To address your point with regard to travel to Alaska, this is something that has also been brought to my attention from local providers. And where they're really struggling to meet this requirement is the need to have that test result back within 72 hours of the person entering the state. So what that does is it really makes it difficult for people to use a high throughput reference laboratory to fulfill that need, just because you've got delays associated with sample collection, shipping it to the facility, and then the turnaround time once it's received at the facility is going to be entirely dependent upon the sample volume at that commercial lab. So for those folks that may be looking to travel to Alaska, I think their best course of action until the different testing modalities become available would be to work through their primary care physician particularly if they're associated with one of the large regional medical centers, which has high throughput testing capacity. The other kind of group of tests that will have less applicability are what we call the serology or the antibody tests. So the antibody tests are designed to detect human antibodies that are developed towards the virus. So an antibody test is not a diagnostic test that is used to determine if a person is infected with SARS coronavirus. What the antibody test is designed to do is to tell a person if they have been exposed to the virus in the past. And so the diagnostic uses for antibody testing are very limited. Where these tests are most effective is when we're trying to do a public health study to determine the prevalence of disease in a population. There are some other types of tests, other types of uses where this may be helpful. The most relevant one is probably in blood donation centers, because one of the treatments that is currently being used in the absence of therapeutics or a vaccine is something called convalescent plasma donation. But I think for the purposes of your group, antibody testing is not going to be anything that you're going to need to be concerned with. So let me just talk a little bit about reliability. That was one of the other things that I was asked to talk about. And I think to really make this conversation work well, there's a couple of really sort of technical distinctions that should be made. And that is when the FDA is evaluating a test, the manufacturer is going to present them with data on the test performance or the performance characteristics. And those performance characteristics, they're going to be looking at two values that have been really played up in the media, but I don't know that they're fully understood. And these are these values are called sensitivity and specificity. So in a clinical evaluation of a new test method, they will calculate something called clinical sensitivity, which really relates to how little of the infectious agent can I detect in a specimen? What's the limit of detection for a particular test? The lower the limit, the higher the sensitivity. When we're talking about specificity, what we're talking about is how likely am I to get a negative result, a true negative result in this population. So how specific is it? Is it going to detect just the agent that I'm interested in, or is it going to cross-react with other things that may be closely related? And so these two concepts in the popular media are talked about a lot. Sensitivity is how low of a detection limit do you have, and specificity is how likely is it to be the agent that I'm thinking that it is once I get a positive result, or what's the value of that positive versus negative result in test performance. The reason I'm going through this sort of technical conversation is what you're really probably interested in terms of practical application is something called a negative or positive predictive value. So this is when you take that test and you put it out into the wild, if you will, to see how it performs with real people that are sick, not with samples that have been used to validate a test system. And here's where the issue with a negative test and a negative predictive value is important. And this is exactly why I'm going through this sort of lengthy discussion. So the difference between the clinical sensitivity and specificity is you're just looking at, balls and strikes. How did it do with a panel of samples that I know the outcome? Did I get it right or did I get it wrong? When you're looking at negative predictive value and positive predictive value, you're looking at ill people, and you also need to look at the prevalence of disease in the population. And that helps determine the value of that test, whether or not you believe it to be an actual negative or a false negative. So when we have a very low prevalence of disease, like we do in Idaho right now, our positivity rates are 4 or 5% at most. Even if you have a test that has a clinical sensitivity of 80%, the negative predictive value is much higher, because the vast majority of people that get tested you expect to have a negative result. So even if you have a rapid antigen test that has a sensitivity value of 80%, if that test comes back negative, the likelihood that that person is actually negative is probably upward around 95 or 96%. So the takeaway message is, even though the test performance characteristics may be a bit lower, the actual value of that negative result in a low prevalence population is actually quite good. And so one of the things that I think is really important, and one of the reasons why all of these test methods are by prescription only, is that you need a trained medical provider to be able to interpret those test results within the context of the disease and how it's presenting in the population that we're concerned with. So they're the ones that can look at, okay, I'm seeing a negative test result. I don't see clinical symptoms or signs that are consistent with a COVID-19 illness, and the prevalence of disease is very low in my population. When you take all of those things and put them together, then you have very high confidence in that result. So that's why I think as you mentioned, it is a bit of a complicated issue, but it's an issue that is driven by more than just how a particular test method performs during its validation. And that's where I think, to kind of circle back to where I started, it becomes critically important to then be collaborating with a healthcare provider so that you not only get a test result from a laboratory, but you get an appropriate interpretation of what that test result may mean beyond whether or not it was positive or negative for the population that you're looking at. So I guess I'll stop there, and then if there's any questions, I'm happy to answer those.
So yeah, no, I really appreciate that, especially the the final synopsis. That really helps. So we do have some groups that are operating in Idaho that are actually providing testing on the private sector. One of those is represented by Tina Upson, and she's with Crush the Curve, and they're doing some really cool stuff. Maybe she can give us perspective of what they're doing, what kind of test you're using, and how you're sneaking around and finding supplies that other people can't, those kind of things, how you're getting it done, and how you might eventually migrate to little places, along the Salmon River or the Clearwater, or, these little almost like MASH units, if that's, the desire. So take her away, Tina. You can introduce yourself and give us.
Yeah. Thank you so much. So like they said, Tina Upson, Executive Director at Crush the Curve, Idaho. And yeah, we get to kind of do a lot of cool things, but it's really because of Dr. Ball and others that help educate us. So we actually know what the heck we're doing, that we're able to kind of go out there and do it. And we get a little bit more latitude and get to operate in the private sector, which can be a lot more nimble, right? So, to where we started off was we're a 501c3, have an executive and a founding board just full of Idaho business leaders and many medical leaders as well. And really just tried to work to solve what could be done, if anything, to help Idaho to reopen, but really ultimately how to focus on in the fall, what could we do to remain open as safely as possible, and help, shore up anything that we could do to help facilitate assistance for medical providers, for individuals, whatever that looked like. We have really close relationships with a lot of corporations, right? So we have over 700 companies that we've contracted with, that we work with them to kind of talk through a lot of testing protocols and whatnot. It's been very helpful. We've recently worked a lot closer with public health, and it has been really helpful for us because what we find are a lot of employers are wanting to deploy, almost unnecessary testing at times, right? And so it's been nice to work with public health because testing is very costly. And I know Dr. Ball doesn't maybe have the details on the pricing, but I can tell you it's expensive, and it is not something currently covered by insurance for surveillance testing. So even if you're paying insurance premiums, that's not going to be something that's covered. And so to be able to lean on public health, we see as a really important next step, specifically so that an employer doesn't feel like they're liable to understand public health at the level the professionals do and make these types of decisions in their organizations. And so, what we've done is we've come alongside and provided a service for employers that would like to execute on testing, that have had people test positive in their organization and wanted to know, now what, or deploy testing. And we've been deployed multiple times into what we call a rapid response type of a testing to test the others within that organization. A lot of times it's done for an emotional reason. They're having a hard time getting employees to come back to work. And so although maybe it wouldn't be considered something in which you would need to deploy it because it's a major public health concern, it's still an employer concern because their workforce, isn't feeling comfortable or whatever that may look like. And the type of testing that we do, we primarily do PCR active virus testing. That one that Dr. Ball mentioned is the most commonly used. That's the testing that we do. We've got a lot of press for antibody testing because we did also allow that to happen in bulk. And that was more for those who were curious, those who believed they had it. It turned out 16,000 plus people were in that group. So we got a lot of press because of the volume of it. But we always wanted to crush the curve in Idaho. And the most important way to do that was to help shore up gaps in, the collection kits to now, gaps in lab capacity, et cetera. And those are the problems that we've constantly worked to solve. What we've done as far as smaller communities, one of the things we did is we went around and partnered with medical partners all over the state. And so I had the team pull a list and, just kind of to see how close we get to some of your smaller communities already. And we do have facilities in Ammon and Blackfoot and Rigby, Soda Springs. We're not everywhere, right? But definitely, hopefully some drive to for some of your outfitters, et cetera. And what we've done with these medical providers is when we first came on the scene, there was very little testing happening, certainly not with somebody who wasn't, it was symptomatic and an essential worker almost exclusively just 8 weeks ago. And in some places didn't even have the capacity to test those. And that's just a fact. And so, we said, okay, well, what would you need? Collection kits was one thing, and we worked to solve that and deployed almost 20,000 kits around the state. I have over 100,000 kits sitting upstairs. I have as many as, we just continue to order them and push them out. But, one of the things, the relationships we have with these providers is that if somebody is looking to be tested, we just wanted to remove a reason they would say no to that. And so if it's testing, collection kits, whatever that is, we're just staying in contact and we just continue to deploy inventory to them. Lab capacity is the next one, like Dr. Ball mentioned. We find that a lot of places have the Abbott ID Now machine, and they're very proud of that. What we find is none of them have a cassette to run it. So it's really exciting, and then it's not. And so what we've been trying to do is until they get the cassettes, we've been pushing to them what they need to do the other types of testing with the PCR. And I think we were talking the other day, I know we just sent a couple hundred kids over to Salmon, right, or to Stanley, or over to Amy's clinic. And so, because she's doing some stuff with some wildlife groups and things like that asked her to have some capacity. So, we continue to try to show up in that way. We've been deployed multiple times for employers in smaller touristy markets. McCall, for example, we've gone multiple times, and this is that employer type testing. And so what happens is an employer contracts with us to be deployed to execute what would be called surveillance testing on employees. And they, we go out and do that and try to, for whatever their reasons are. Sometimes it's for consumer confidence, employee confidence, et cetera. It's separate from doing testing because of known exposures, right? It's more of they want to proactively execute on a testing event, and a local clinic wouldn't have the capacity to do that. So those are some of the things that that we work to do and, kind of work towards. We've increased our lab capacity. We're up to 16, we can do a little over 16,000 tests a day through our connections. And so that's where we're at on our capacity. And I think as a statewide, it's continuing to grow at each of the medical providers level. Our hope is to just, continue to see that ramp up and not run into that issue here in the fall. I think that's in alignment with everybody's hope. So, we're definitely constantly looking for ways we can help out and show up for communities. We've talked about if there is a need for surveillance testing, and I would defer to public health to let us know in the governor's priority groups for the outfitting groups. And that's something that, can't be done at the local level potentially. We can deploy logistically, to be available on certain, calendared days for employers, right? We could look at doing something like that. Again, guys, I would really lean on public health as the experts for whether or not that is necessary, because it can be costly. And I think past that, there has to be a plan in place for when you do find those positives. Otherwise, all you're really doing is just the what. And that's, that would be the next thing to consider. And like I said, our goal is to continue to work closer and closer with the state so that we're not just kind of letting you know, like, okay, here's the info and you do have positives and then see ya, right? So we're trying to really help with that as well. And that's what's been our focus.
Well, thanks, Dan. You know what, you use the term emotional, and I think, in business, that's a great term because it's, I see that we do a lot. We try to look good, with our decisions. And then sometimes we do what is good. And anytime you can do what looks good and is good at the same time, you're always better off,
Sure.
And so when I look at a small town, there's, you get that whole dynamic. There's the people, that are waiting for the bar to open up, but there's also the people that don't want intruders bringing the disease. And so the emotional aspect is really important and shouldn't be, it shouldn't be underestimated in a value, even though maybe in the long run it didn't really mean anything. But the notion that, outfitters could say, hey, we're testing our guides, even if it was once for the season or whatever, if that put folks to rest, maybe that's a good thing. I don't know. I'm just, just wondering. So, so the next question I have for you, just real quick, is, you talked about helping out where needed. Let's say a small town in Idaho wants to do something more. You got a clinic that's struggling, wasn't aware that, you might be a resource. I assume they just get online, find Crest the Curve and make a comment just like I did to track you down, right? I mean, that's where
right,
it begins.
Yeah, crushthecurveidaho.com, and they can just do a contact form. And we have, they would most likely end up being a medical provider partner that we would have. And then we would just find out what their needs are. And if we don't already have the tools that they're in need of, we'll go find them.
All right, cool. Don't go anywhere because I'm sure we're going to have questions for you. So
Okay.
You hang in there. So Dr. Matt Dawson, he is the CEO of Wild Health, and he's already providing service to some of the outfitters in Idaho. He's got an interesting way of providing testing. He's an MD and he's an entrepreneur as well. So why don't you take it from there, Dr. Dawson? Are you with us?
Thanks, Steve. Yeah, can you hear me okay?
I think so, yeah.
Great. Yeah, so we actually are a genomics-based precision medicine company. We are approximately 40 MDs and PhDs. And this is not what we did prior, but we happen to have a high complexity CLIA lab just from our genomics work. And so when COVID hit, our lab director is a PhD in infectious disease and genomics as well. So we immediately started trying to help our patients with COVID testing because resources were limited at first. So we started doing the CDC gold standard RT-PCR testing, which Dr. Ball gave a great rundown on. We also have the Sophia 2 and the Abbott ID now, and we also have a Cepheid machine that uses a LAMP technology. But primarily we're doing the RT-PCR testing. And pretty early on, we were asked by quite a few of our employers that we serviced about testing larger groups. Everyone knows we have to eventually open back up, but we have to do it safely. So as we started working through the problem of how to test larger groups, we realized there was a solution out there, but just not a lot of people were doing it yet. There are a few groups doing it, the state of Nebraska, Israel, India, a few other places. But the concept that we think is kind of ready at this point, since we're looking at low prevalence groups, asymptomatic, is a concept called pooled testing. It's been around since the 60s, but hadn't been applied to COVID very much, other than, like I said, in the state of Nebraska and a few other places. So with pooled testing, if you have a larger group of individuals in a low prevalence situation, what you can do is, say, for example, you have 300 people that you need to test. That's expensive and that's a lot of resources. But if you take those 300 individuals, you swab them all, you then divide them into 30 pools of 10, and you run 30 tests initially. If everyone's negative, if all the pools are negative, you're negative. If the prevalence is 1%, meaning 3 people have the virus, then you're going to have 3 pools that are positive, So 3 pools of 10, and those individual samples are simply ran again, and you ran 60 tests instead of 300 tests. So it's a method just to more efficiently use resources and test larger numbers of individuals at once. Our first question when we saw the first reports on this was there a problem with dilution? If you're taking samples together, you're going to dilute out enough virus to be able to amplify with PCR. But there was a great paper in the Lancet where someone validated that pool sizes up to 30. Your cycle threshold is just fine. It works well. And from a practicality and math standpoint, pool sizes larger than 12 don't work anyway, because if the prevalence is 1%, your ideal pool size for maximal efficiency is 11 to 12 anyway. So it's a method that is being used, not being used widely yet. It's starting to be used state to state and with asymptomatic people. It does not work when you're talking about symptomatic populations, people coming in with symptoms, because if the prevalence is 5%, 10%, then all of your pools are positive and you don't have any efficiency gains. So it's something that we've been trying to kind of spread the word on, trying to get other labs to do as well, because we think it is a nice, efficient solution to testing larger groups in a quick manner.
All right, well, good. So why don't you just nuts and bolts, let's say I've got 10 guides, I want to test them all. How would I get that done in the next week?
Sure. So to be honest, with 10 people, pool testing doesn't make a lot of sense because it's really for a larger group. So 10 individuals, it'd be easier just to do an RT-PCR on all 10. You don't gain a lot of efficiency there. But the test can be done with a qualified professional there. We can do some telemedicine assistance to make sure that the swab is done correctly. The swabs are then overnighted back. The test is ran and you have results. You need to have someone there who can, as other people have talked about, can actually help interpret, because what do you do next if you have a positive? That's a question that needs to be answered ahead of time. But it's and obviously this has to be done in a high complexity lab as well, because it is the RT-PCR. You have to have special equipment to do that. So it sounds like, honestly, in Idaho, you all have a lot of resources already. You've got a lot of solutions to this problem. This would be kind of an extra solution if there were larger groups and if there was not enough testing available. But the logistical issues are getting the supplies, having a medical professional do the swab, sending them back, and then getting the test. When we receive a test in the morning, we're having a result that day, usually by the end of the day. So pretty quick turnaround times on the test as well.
So I'm going to turn this over to both Tina and yourself. This is a commerce conversation. So let's, what are we talking about cost? Like what, somebody wants to walk in with their crew, what's it going to be, a pop to get tested?
Sure. So I can speak to ours, right? So we have programs maybe similar to what was kind of being discussed that we utilize for asymptomatic larger groups that have medical staff, right? So we have a program where with assisted living facilities, for example, they have medical personnel on staff, and we'll drop ship to them everything they need, including training collateral for them to execute on a testing event for asymptomatic, all of their patients as well as their employees. And then we send them again, whatever their interval is, all they need to test the employees again, right? So in doing that, we're able to bring the cost down. Right now, we're at $30 a test in doing that program. That's a significant discount because we remove a lot of pool booths along the way. Plus, like I said, we're in the private sector. So, I just put a bunch of money in escrow and I got a lab to cut us a really sweet deal, right? So I can do things like that. And, I just can get around some stuff. So $30 a test is how that program works. If you're saying, when you ask that question of, hey, I have a group, I think the next thing for me comes to mind is, well, what are they walking into? Are we setting up a site logistically and some of those costs? when we're doing more of asymptomatic group testing at, let's say, like our 10-mile site here in the Treasure Valley, or when we've set up before in the Magic Valley, the lowest we can get that because of other parts and pieces is about $50 per. But I mean, you know, 3 weeks ago, you couldn't have seen it go below 95. So it's just one of those things that gets closer and closer to home, like Dr. Ball talked about with the rapid antigen testing. I mean, those are where we're all trying to drive to. But for right now, you know, from a cost planning perspective, the lowest you're going to see for asymptomatic, at least for us, is going to be in that 30 to 50 range. I can't speak to what they're doing with this other program.
Appreciate that. You got anything to add to that, Dr. Dawson?
No, the $30 to $50 range is exactly pretty much as low as it can get. It depends on the size of the group and if they had their own supplies and other logistics. But yeah, that's when this first started, as Tina said, I mean, we were looking at a lot of places were having cash prices of $150, and a lot of people are still charging that. But now there is availability out there, and luckily it is down more in the $30 to $50 per person range.
Appreciate that. You know, I had an extensive call with the nurse down in Moab, and he was also in charge of the billing. He was doing it all. And to date, he had not had an insurance company deny a claim for the cost of testing. And they're doing 200 people a week. Now, that doesn't count for the people who are uninsured. So
is that here in Idaho, Steve?
That was in Utah.
Oh.
No,
they're probably on Select Health, because Select Health is paying everything. So we have not seen anything denied from Select Health in Idaho, including antibody testing. To be honest, they haven't denied anything.
Yeah, Tina, Jeannie, Chris, to what extent in Idaho are you seeing, like, I mean, Tina, you mentioned when we spoke previously that Select Health seems to be the one that does cover. I mean, is there any other insight to, like, in rural clinics or more broadly about what coverage is being provided or what claims are being accepted?
Yeah, I think there seems to be that Pacific Source does cover a little more than Cross and Shield, but Select Health has been the one that's just shown up and has covered everything. Currently, we have had no luck with Cross and Shield unless they are sick and getting tested for COVID. So, for example, even if we go into a meat packing plant that's 20% positive, and all those people are paying Blue Cross premiums, and we test everybody else and find 50 more positives, we still are not getting Blue Cross to reimburse against that. That's just the reality. I mean, I'm not, I'm trying to pick political anything because I don't care about that. I'm just telling you the truth.
Jeannie, how about yourself? What's your experience?
So we're, in the medical business. so we're testing people asymptomatically, or a few months ago, about a month ago, we started testing everybody before surgery, pre-op. But those are the tests that we're doing. So we aren't seeing a whole lot of rejection of claims because there's medical necessity there. Different ball game, like Dr. Ball was trying to explain to us. It's a different kind of ball game than testing a largely asymptomatic group.
I would think too that if we start discussing insurance, probably one of the largest uninsured groups in the country might be my guides. So, the reality is that somebody's going to be, fitting the bill for the frontliners of the commerce industry, whatever that would be. I would say that they're probably a large portion of the uninsured of the world. I think we probably have some folks that are in the audience that are considering being benefactors to the guide industry. We had some folks trying to think of something they could do to help the industry and make guiding a little safer through all this. And so funding might be available to do some testing with guides. I know that that's been a discussion over at the Red Side Foundation and whatnot. Aaron, do you have anything to add to that?
Well, I was just going to ask, insofar as there is a stop, and I guess this is maybe mostly both Tina and Dr. Ball for your connections in different degrees, either to the testing task force and to the governor's office, whether you have any insight to in the recovery and or testing plans if there is an intention or possibility of additional funding or support being given to non-covered individuals or, broadly put, communities, industries, given that shortfall in coverage for testing?
That's a Dr. Ball question, not Jason.
Okay, thanks, Aaron. I can take kind of a stab at that question. The testing task force was put together at the end of April, and really what we were tasked with at that point was trying to get a sense of what level of testing capacity was currently available in the state, and to try to project forward as to what we thought testing demand would be. So that's what the testing task force has completed to date. What we're turning our focus to right now is moving to, now that we have some projections on what we think testing could look like, how do we get from where we're currently at to being able to fulfill all of those potential tests that may come down the pike? And as you might imagine, that is a much bigger and more slippery type of problem to get your hands around. And so we're really looking to partner with a variety of different stakeholders, because there's, quite frankly, a number of those questions that we just don't have the skill set to answer. So for example, as a public health professional, I really don't have a good sense of what the folks in the insurance industry are going to cover, what they're going to, how they're going to relax or define what medical necessity means, and whether or not they're going to relax that definition to broadly include public health populations as something that is a medical necessity that can be covered by insurance. Alternatively, depending on if people have Medicaid, they still need to meet some requirements to be eligible to get their claims processed by Medicaid. So we've been working with the Department of Insurance and Director Cameron to try to continue those conversations. Likewise, we're also working with community organizations like Crush the Curve Idaho. We're working with hospital providers. We're working with a variety of different stakeholders, retail pharmacy, academic pharmacy, to try to identify what the needs are. And really one of the things, as I mentioned at the outset, there still seems to be a lot of uncertainty and things that are very unsettled about cost and how to provide testing for underrepresented populations and those that don't have insurance. Historically, what I can tell you is that public health has tried to provide support for folks that don't have access to care. Now, whether or not that means that we will be able to fulfill that moving forward, I think still remains to be determined. But those are definitely the challenges that we're trying to work through right now, because what we're seeing is demand for testing out of the predominantly medical sector is really starting to increase. And we really need to have some effective solutions for how people can handle this outside of an employer mandate for, worker safety. So it's a challenging question to answer, and I've probably done the best I can to tap dance around and not answer for the last couple minutes. So.
Well, Steve, if I could, I realized after the fact, and thank you, Dr. Ball, I realized after the fact that I should have maybe also directed that question to Dr. Carter at Department of Health and Welfare, see if she might have any additional insight. Because really the question of if we have these subject classes, these groups who do not have access to or are not covered by testing, then a crucial problem for the state and or for all of us to solve is how do we do that? And I don't mean to push this away from outfitters and guides. I think that we probably are a very representative class in that way. Guides in particular, people who generally do not have coverage and almost, probabilistically speaking, don't have select health if they do. So I think it is kind of an important one. Dr. Carter, do you have anything to maybe add to that? Any solutions or answers for us?
No solutions or answers. I think the question about payment is very challenging and nobody seems to have the answers. I've asked for a one-pager from somebody about who pays for what when, and we hear mixed reports. I've heard from public health districts that, oh yes, testing is free, but when our clients go to providers, they're still getting billed $80 to $200 when they get tested, which is definitely a deterrent for asking people to get tested. So there does need to be more clarity on that, and we need to, we need to have more options. I have no answers at this point.
So,
Tina, I think I skipped over you there. I'm sorry, Steve. I think I skipped bad Tina there. No, I didn't. Okay, go ahead, Steve.
So we've got Amy from the wonderful Amy Klingler from the Stanley clinic is on. I think we can turn her on. Maybe we can hear her. And we've got Jeannie. And then I've had long conversations with Steve Rembelski from the Chalice Area Health Center. Amy, are you with us out there? She's muted. We'll get her unmuted maybe. This is that technology that I have no responsibility for. Oh, there we go. Are you there, Amy?
I'm here. I just need 1 second to do something.
Okay. Make sure it's not personal because we can all hear. So anyway, what I'm going to do is open it up to you two. What do you see as the shortcomings? You're on the other end. You are the frontliners in rural Idaho right now. What are you anticipating? What are you needing? Where's the support coming from? Where isn't it coming from? Just think, that's an important component of all this. Why don't we start with you, Jeannie?
Okay. We just this week have been able to secure a few dozen test kits from the state, which is great. We have had to send everything out to either the state reference lab or our other reference lab. And the turnaround time has been anywhere from 3 to 7 days for us. We have the equipment, the Abbott equipment. Now we have the proper test kits to do those here. We have to go through the validation of our equipment, but we will be able to start doing those next week. That will give us a quick turnaround time, same day type turnaround time here in Salmon. We struggle with, we don't typically do large groups of employers. That's just not something that we've been set up to do for asymptomatic patients. And so up to this point, like I said, it's all been symptomatic patients that present to us medically, and including pre-op patients that we want to ensure don't have COVID before we open up their skin and, expose everybody or them or whatever. So I would like to be the resource for our community, but I know that there's no way I can do a test like that for $30 a pop, just because of the volume that we do. And so we're trying to see where we fit in all of this and how we can best serve you, because the outfitters and guides are so important to the community of Salmon, as well as your clients that are coming here to visit. I'm thinking that, we probably still maintain the same medical service role, but we need to have your help in figuring out what is best for us to do, what's best for Tina's group to do, or, another, Dr. Dawson, or some other model like that. And maybe some of you can speak to that.
So Jeannie, is it fair to say that the supplies you have now are limited to the medical end of things? You're not going to open your doors to any kind of commerce testing, is that correct?
After we do our validation studies, we'll have about a dozen test kits. And we're told that we can get more, which is great, because that's been a problem at least for our surgery patients. The turnaround time, making sure that we have the results back by the time their surgery is scheduled. But I don't know if we can get enough supplies to, let's say, the Forest Service or the school district. here when they go back in the fall, if they want to have all the school district people tested or something. That's not something we normally do, and we don't have facilities to run dozens of tests like that per day.
So the question is, do you want outfitters to be calling you or not? And I'm hearing no. At this point, you're not set up to do that, and somebody that's trying to just get their guides tested willy-nilly probably shouldn't bother you with that question. Is that fair at this point?
So at this point, I don't know the answer to tell you a cash price that's competitive with the other ones that are available.
Well, I'm not worried about
Steve, she's saying she has 12. She has 12 tests, right? And so
right.
like the answer is fundamentally no at that point.
Even
And
if
so
it
the question is the question I do want to go to Amy here as well to get her perspective. But the question is, like, what are the opportunities to change that obviously untenable situation where you're wondering if you can test Forest Service employees, which are many in there, not least outfitters guys, nor people coming in, nor school children. And I know, I mean, Steve, you mentioned 1 million people going through Stanley. Amy, can you speak to what your opportunity or what your capacity is right now for testing? Amy, you're still there? Did we lose you?
Amy's running a test right now, but she'll be back in just a minute.
Oh, she's so dedicated.
Ironic,
well, who are you? You're not Amy at all.
So in the meantime, while we're waiting for Amy to respond, Tina, you said that you're doing some tests in salmon. So how does that work?
Yeah, you know what I did is I said salmon instead of Stanley, and then that's super insulting to everybody that knows there's a major difference there on this call. So I apologize for that. But what I would tell you, Jeannie, is what we could do, right, is, we could, because these outfitters don't have a medical team, right? What I could do is just let you know how we work with other medical partners for you to provide the clinician on the ground. We basically contract with you as a vendor for us to deploy mass testing in your area. And we just say, hey, we're going to be in town a couple days a month. And it's, you're going to help us with the medical person that's going to help do the swabbing. But, we can logistically, bring all the kits, et cetera. The lab that we utilize for that kind of testing, as long as we get it out by 5 p.m., we're getting results the next afternoon. Typically with asymptomatic anyways, though, it's not even as much of a rush order as when we've gone into a hot spot, right? So, from a resulting perspective, worst case scenario, they're waiting 48 hours if we miss the FedEx that day or something. But, we can certainly organize something in your market and still keep you involved at whatever level you want to be, because we would need a medical provider because they're not, currently going to have one.
So, Tina, Crush the Curve is a government kind of program to help with get all of the employees back to work, right? I mean,
it's a 501c3. It's a private entity, actually. But we do work, we do have, we work with the government on certain, maybe, certain different deployments that they may need, et cetera. But really, we just have, we have testing capacity, we have lab relationships and contracts and things like that, and they can be utilized by anybody in Idaho. We just have different latitude, kind of like you spoke to you not having because you're a medical professional or, or because, some people are government. We're not either of those. So we just have a little bit more latitudes of areas we can play in. But yeah, we can definitely connect offline and organize something for your market.
Yeah, I think we really need to, because we would like to provide the testing, and we have couriers that can go places and take test results in too. But we need to have a little bit more discussion of resources for the community here, because like I say, it's just not what we normally do. We normally take care of sick people coming in. And we would like to test all the not sick people, but we're just not yet set up for that.
And
looks like
Jeannie, and I want to say I love that the conversation that was going on there, because that was really my hope. So we talk about like what we can actually do to change things and make things more effective. But Amy did have her hand up, and Amy, you done doing that test yet?
It's running. It's running. I have 12 minutes, I think. So speaking from Stanley, we were able to partner with Crush the Curve early. We had some local people who were involved in Crush the Curve, and so we partnered with them initially for antibody testing, and through Crush the Curve, we were able to get a contract with the University of Washington for antibody testing, which was our initial interest, and you know, establishing sort of prevalence of COVID in Stanley and in our community in, you know, March and February, wondering if these illnesses that people had in February were COVID related, those sorts of things. Our proximity to Blaine County was obviously a concern because of just the prevalence of COVID in Blaine County in March and April. So since then, you know, we are closely affiliated with St. Luke's Health System. So all of our routine labs go to St. Luke's. And when St. Luke's started to do antibody testing in-house, we moved more of that in-house, partly because it's less work for me, to be honest. The way the results go, and I felt like you know, it was just a progression. The cost was similar for patients. We have continued to work. We've also done all of our PCR testing so far through St. Luke's. So we're kind of in the process of transitioning that because of this question of resource availability and what's going on. These last 2 weeks, we have started doing asymptomatic testing in the guide and outfitting community. To be honest, I still struggle with it because we're doing a lot of asymptomatic testing, which is a little bit uncomfortable for me when, you know, it's a scarce resource. But so far, I haven't been told that it's inappropriate for what we're doing. It is a priority 4 from the testing task force, so it's on the list. You know, my goal is to not use, you know, my thought is, and I'm keeping in touch with the St. Luke's folks to find out if we are maximizing capacity at St. Luke's, that we need to go to University of Washington, who is willing to run PCR tests for us. So the process is the same, that we would FedEx samples to the University of Washington and get results back, you know, 24 hours after they receive it, which would be probably 48 hours from the time of collection, realistically. So that's a pretty reasonable turnaround time, except for it's challenging mid-season for guides who, you know, have a 24-hour turnaround time between, say, Middle Fork trips or something like that. So in that regard, we're using the Abbott ID Now. We did get one of the machines from the state. It was originally, the machine we got was originally given to the Chalice Area Health Center because Chalice was located between you and me, Jeannie.
Yeah.
They thought that they would sort of be the middle person for us, but they found that Chalice had a machine that could run the Abbott ID Now. It was a different machine. So then when I heard that Chalice got a machine, and I contacted District 7 Health Department and said, hey, how do I get one of those? When it turned out that machine, there was an extra machine, we were able to get it here. We've done the validation testing on that. I did the training with Abbott last week, and we started running samples yesterday, actually. The people, I'm working on sort of an official protocol for the people to run those tests on. What I've done so far is people who are symptomatic, who are, you know, have close proximity with the public, who live in communal living. Two people yesterday were Forest Service employees, and one person yet today works at a local restaurant and is symptomatic. In the testing task force guidelines, the goal would be that the majority of that asymptomatic, you know, river outfitter testing could be done with this point of care machine. So again, that's sort of contingent on supply, and maybe Chris can speak to that a little bit. I've requested supplies and I've received them. So I'm hopeful that that will continue. I'm trying not to be too greedy about it, but I'm super grateful to the state and to the Idaho Bureau of Labs for working with us, for seeing the need, for the testing task force, for acknowledging the problem that we have with our tourism industry and with these employees and outfitters who work in close proximity with tourists. So this balance between, you know, commerce and public health is really critical in our community. Dr. Souza early on in our last call talked about the public health emergency of COVID-19 and the public health emergency of keeping our economy shut down. And I've really thought a lot about that. And I think we really have to find a balance, and this is what we're working towards.
So Amy, just a quick question. How many tests do you have? So Jeannie's over here hoarding all 12. How many, which is, you know, we're not even going to get into the selfishness of that, Jeannie. But Amy, Amy, what does your supply look like right now? And then you did direct a question to Dr. Carter. I did want to interrupt that.
For the Abbott ID Now,
yeah.
We have, as of yesterday, we should have 125.
Good.
So the real important thing here, Amy, you need to save 2 of those for me so I can get to Alaska. That's the only thing I'm going to say about that.
I halfway suspect, everybody, that this is why Steve wanted to put together the symposium.
You already told me the most important question yesterday was our discussion about Alaska.
That's right. Amy, what I'm sorry, Steve, I didn't know that you were, I think you had a different area to go here, but Amy, you asked a question to Dr. Carter, then I interrupted it. Did Dr. Carter, do you want to speak to that?
Oh, Dr. Ball.
Oh, sorry, Dr. Ball.
Sure. Amy,
oh, just from the lab stamp, you know, from the Bureau of Labs, sort of, my goal is really, should we be working towards our asymptomatic guide testing being done with our Abbott ID Now machine from the state? You know, my thought is reserving a certain amount for symptomatic people, asymptomatic people, kind of dividing that up has been a little bit of a challenge.
Yeah, I think that's a really good point. And so we received we'll continue to receive an allocation of ID Now test reagents to support the state's testing mission. And what I would say to that is, keep in mind the priorities that we've established, and really the intent of the testing task force is to make sure that you have enough material on hand to test those folks that are the highest priority for need. And then as long as you have existing materials on hand to test that population, if you have additional people in lower priority groups that need testing, then it's perfectly applicable to use those materials as long as you've got enough in reserve for the sort of critical need. And then I guess probably good news for both you, Amy, and Jeannie, is it does look like we will continue to receive an allocation of ID Now test kits on a weekly basis for the rest of the year. And so we'll be reaching out to you separately to kind of talk about how best to efficiently make sure we get materials where they need to go.
Thank you very much, Dr. Bell, and we appreciate your help. And I'm sure Amy will send you all of the patients that come here if we don't have tests. No, just kidding. But we do want to serve the guide community. Like I say, we want to be able to have a good turnaround time for you all so you can continue your businesses. I know how important that is, and it's important to our survival to keep that a healthy industry in salmon. So we'll do our best to get things figured out.
I have a question.
Doctor. Yeah.
I have a question, Dr. Ball. You know, so this is priority group 4. And, you know, when I hear the medical providers wanting to show up for them, at what level how much testing is being, you know, asked for that priority group of asymptomatic, right? So I understand prioritizing the priority groups, but how do they even know what that number is unless they know how often they should be testing, right? So I can take my priority 1 people in my community. I got to know how often you would want to see them tested to be able to preserve enough to be able to provide that. So with group 4, what's the recommendation for these guides? How often should they be testing their people?
This is a really good question. It's one that I really struggle with. And I think it's really important to note that testing is just one part of a strategy to reduce disease transmission. And arguably, it may be one of the least important pieces to reducing disease transmission. So particularly in a situation like your outfitters and guides, if you're taking a test 24 to 48 hours before you get ready to go on a trip, you have to keep in mind that what you're getting is a snapshot, a point in time glimpse. So what that means is that at the time that swab was collected, you were not infected with the virus. So that doesn't extend to what happens 24, 48, 72, a week later. And so I think if you focus this on a prioritized testing basis, if you're really looking at testing is going to drive what we do afterwards, then really the only way that this is going to be effective is if you've got a pocket full of tests and you take one every morning when you get up. And I don't think that that's practical. So I think to kind of go to the point of should we be testing, well, I think that there are certain instances when that would be helpful. And I think it speaks to what Steve was saying earlier in terms of sort of presenting to your clients, yes, we're taking your safety and the safety of our employees very, very seriously. And we are providing testing when we feel it's appropriate. But I think it needs to be combined with, look at all the other things that we are doing to ensure that we preserve your safety. So it needs to be combined with all of the other proven public health mitigation strategies in terms of proper hand hygiene, sanitizing regularly contacted surfaces, and trying to distance people as effectively as possible, which I realize when you got 6 people in a raft is like, you can't do it.
So I think, Dr. Ball, if I could just interrupt, and I'm sorry for pressing you, but it seems that we got away from the question pretty quickly there.
Mm-hmm. Yeah.
Like if the question is establishing allocation of different priority groups and what the state envisions as that allocation based on the amount coming in, like I mean, I am by no means. I have no expert status in this whatsoever, medically or otherwise, but it does seem that if outfitters are asking themselves, and really people who are providing a service and providing consumer confidence and providing the economic activity that people who live in places like Jeannie or Amy or all of us need to be able to survive as communities, then the question of to what degree, how often, and how, and where's the availability of that testing coming from, does remain the fundamental question, right? Because it ties into consumer confidence, even beyond the efficacy of that toward actually flattening curves.
Sure.
Am I off base there?
No, I don't think you're off base, and I think it really speaks to the point where, although testing capacity is increasing, we're not at the point where wide-scale serial testing of asymptomatic people on a routine basis is going to be a practical option right now. I think we're going to have to wait until we get the availability of mass-produced rapid tests that are available in a point-of-care setting to make that something that we really have the bandwidth to deal with. And I think that speaks to the question that Tina was offering. If the recommendations from the task force were to start with priority 1 and work your way out, and guides and outfitters are asymptomatic guides and outfitters are in priority group 4, then I don't think that routine or serial testing is probably consistent with the level of testing availability that we have. Now, does that mean that you shouldn't do it? No. Does it mean it's the best use of state resources? Maybe not. But on the other hand, there's a potential that you could have a real significant outbreak associated with a float trip. So there's an argument to be made where are you likely to get the transmission? Is it from the folks that live in Stanley all the time, or folks that are flying in from all over the world? And so I don't have a good answer for you other than to say, with the current state of testing capacity, we don't have the ability to test all the people that may want to be tested when they want to be tested. But I'm optimistic.
So, Dr. Ball, if we had no constraints on lab capacity, and we look at the priority testing guides from the governor, right? There were numbers that said if we were doing what was recommended as a state, there was like a number that would be tested a week. So what
Right.
mathematically for outfitters or priority group 4, was it a monthly or every 60 day, or, you know, what was how did the number come about? Or was it kind of just like a really good, like, swath guess?
It was the later, Tina. So it was really kind of an estimate, and then we tried to get a kind of a median value that we put limits around. But there's really no way to get those hard and fast numbers. I wish I had an easy answer, but it's just complicated, and that's the frustrating reality of it. It's complicated, and we don't have enough materials to do what we want to do, and we don't have enough money to pay for what we want to do.
So, folks, we've kind of eclipsed the 90-minute meeting. I see Amy's got her hand up. I see some people in the audience have some questions. The reality is we're affecting thousands of businesses and millions of dollars here. So if you're willing to bear with it a few more minutes, I think it's worthwhile. I think we're getting down to the crux of the discussion. I'd like to turn it over to Amy's comment or question, and then Aaron could tackle some of the questions, and we could call it good for the day. And then so that everybody's aware, we have a time slot scheduled with Dr. Souza next week. And that agenda is not necessarily set. So if this could morph into a continuation of more specificity, like to how Crush the Curve could help specific communities, we can do that next week. So I say we go to Amy, we go to the questions we got from the group, we sign off, we thank everybody, and let's go leave it with that. So Aaron, why don't you lead Amy through it, and then the rest, if you would, please.
Absolutely. Yeah. And thanks for that. That certainly wasn't actually scripted, but this has been incredibly useful. And I feel like we're just in the cusp of figuring everything out despite all the complexity. Amy, did you have a question or was it a comment?
It was just a comment. You know, one of the things that we've been, you know, kind of trying to balance is the whole commerce and life and everything. And I really appreciate Dr. Ball's comments, because looking at business and looking at people, number one, if they're traveling to Idaho from out of state, they are accepting a certain level of risk. And so we, you know, I don't know that we're going to be able to reassure every tourist who's coming in here that every single thing is going to be safe. And it's just like, you know, me going to visit my grandmother, how, you know, what level of risk am I willing to take? So I think we definitely have to consider the big picture. And so we consider what our resources are. Obviously, our first priority is testing and treating patients who are sick with symptoms. Taking care of the guide community certainly falls in there, but the asymptomatic guide communities will have to fall behind the sick patients, unfortunately. And then the idea that you may not be able to reassure all of your guests all the time that everything, that they won't potentially get sick if they come to Idaho and go on a trip. So it's just something to think about, the realities.
I'm muted. Yeah, no, it is a trade-off. You know, we've had some conversations with folks who really do, or the conversation's gone somewhat differently. And when Steve and I were able to talk with you, Tina, you know, we certainly brought up that there's, and Dr. Ball, I think you spoke to this as well, but that there's a reality to needing to provide that consumer confidence in order for these rural communities to survive. I mean, that's they don't do so without the kind of recreation tourism that outfitting and other activities bring in. But I'll stop waxing there and to hit a couple of questions that did come in. Somebody contributed that somebody in the salmon community, so maybe Jeannie, you could speak to this, had a COVID test done 9 days ago or so in salmon. And I guess the emphasis there was on how long it is taking in rural areas to get some of these results. And Amy, I think you mentioned maybe a effective 48-hour turnaround using the Epic Quick Test. So I guess the question out of that is, what is the spectrum of test result turnaround in different areas of rural Idaho, and going also maybe, Tina, to areas in East Idaho, and what realistically can we get that down to? Or what does it take to do that? Does anybody want to tackle that one?
And let me just say, from the salmon area, we just got the test kits for the equipment that Amy and I have both talked about. So our turnaround time should be a lot quicker starting next week after we get our test equipment validated, because you have to use some of the kits to validate the equipment. So we'll be having a shorter turnaround time soon.
Okay. Unless there's anybody else that wants to weigh on that. Another one is, we have another question from somebody. It says, the last time we'd have some discussions with folks in the medical community who mentioned development of a saliva test, and I'm guessing that it's different from the swabs in this question. What type of test would that be considered, and has there been any forward movement with this development? I think that was to Dr. Ball.
I think that there is discussions amongst some of the laboratory community about trying to validate saliva as an alternate method for a lot of the high throughput tests. Many of the rapid antigen tests that I referred to earlier may very well use saliva or oral fluids as the test matrix. At this point, it's a project that we're working on, but it's not quite ready for prime time yet. But definitely, we feel like if we had a non-invasive sample like that, it would be much easier for folks in the community to both have access to testing and maybe be willing to get tested. Because I don't know if any of you have ever had a nasopharyngeal swab, but you're probably only going to sign up for that once. It's not the most pleasant experience. So I would say stay tuned. There are a couple of large reference labs that offer saliva-based testing. I think it will be forthcoming, although I would caution and tell you that what I've seen in the kind of larger laboratory community is they're getting really mixed results with asymptomatic people using saliva as a test matrix. So the performance doesn't seem to be as good.
All right, thank you. The next question we have, and some folks did respond in the Q&A to this, but I think it's a question a lot of outfitters are asking, and maybe it's beating a dead horse and trying to ask it here again, but folks are looking for the bottom line, right? Like, should I get my guides tested before they show up for the season? Should I do that before trips, after trips, like, which is sometimes 18 hours spent outside in the wilderness? Like, is there a best, at this point, given availability and given reliability, is there a best for now suggestion for people in the industry who are operating right now and who are, you know, on the cusp of really exploding into a big season?
Who is that directed towards?
anyone who can take it.
It's like
All
this
right.
nose goes.
Yeah.
Whoever doesn't have
Yeah.
their finger.
Well, so I think, you know what, let me so unless, I'm sorry, Dr. Bell, did he have a good answer to it?
I was just going to say I don't have a good answer to that question, but I do need to sign off here pretty quick because I need to jump onto a different call.
Sure.
But if you would like to take this conversation up next week in another forum, I'd be happy to participate.
Yeah, absolutely. And before we lose you, because I'm going to use the law of verbal traps to get you to commit more certainly. But I think what Steve and I and Jeff and others with an IOG I talked about beforehand, and what I really think is urgent for not just the industry, but in particular, because the industry is inseparable from places like Salmon, Stanley, Riggins, all these small rural towns across Idaho who are bereft of resources. I think one of the opportunities one of the things I was hoping to come out of this, and which I think we're really on the cusp of, is the people most engaged and most informed about this issue identifying what opportunities, shortfalls, or, you know, what can we do going forward. We know that this is a thing. There's no shortage of problems right now across the state, not least in outdoor rec. But this is certainly one where there is very little attention, not least with the connection to rural Idaho. So I really appreciate it. I know I'm not going to, Steve, I'm going to pass it over to Steve, but I just wanted to say that I really appreciate your time. We went far longer than we asked you to, and it means a lot. And if you are willing, which I see all these head nods, and I'm going to take that as a lot of verbal traps or acknowledgement that we can get you on the Souza webinar. It's going to be next week, and I'll forward you all on the information. All the other folks on the call here should have it. But for my part, I'll pass it on to you, but I just want to say thank you.
Great, thank you. I do need to hop off the call, but I really appreciate the opportunity. Thank you very much.
Appreciate it, Dr. Wall. So I'm just going to end it with, thank you very much. I think it was awesome.
Thank you.
The last thing I want to say is that don't forget that this will be recorded. We're going to figure out a way to share it with others, because obviously on a short notice Thursday afternoon, not everybody that would want to be in on this could be. So, at your leisure, or, if there's anyone I would pass it on that somehow or other IOGA, specifically Aaron, will make sure that this becomes available, and there's a link out there somehow. I don't know. I'm not the techno guy. So with that, we're going to say thank you and sign off. So thanks, everybody.